Welcome to Healthy Buzz, the podcast for women who are craving honest answers in a supported community. Hosted by Brandy Homerding, a certified nutrition therapy practitioner who believes your body isn't broken, but the narrative around women's health is. Each week, we're diving deep into holistic health topics, challenging the one-size-fits-all approach, and empowering you to trust your own informed intuition. Get ready to feel seen, supported, and seriously informed. This is Healthy Buzz, where collaboration meets unfiltered transparency in women's health. Welcome back to another episode of Healthy Buzz. Today, we are diving deep into the world of thyroid health and how the thyroid impacts your overall health. We'll be moving far beyond the normal TSH test and exploring the critical difference between normal and optimal lab values. And joining me for this conversation is Alison Percowycz of Well North Functional Medicine. Alison is a family nurse practitioner who is passionate about finding the root cause. Alison is a board-certified family nurse practitioner and functional medicine provider. She spent 15 years working in academic medicine, where she realized that actually getting and staying healthy may need an unconventional approach. She sought out a more integrative, holistic approach and began studying at the Institute for Functional Medicine, where she was certified in 2023. She has a passion for all things women's health, from painful periods to pregnancy to perimenopause and everything in between. She enjoys delving deeply into patients to understand things that are interconnected and how to achieve optimal, lasting health. Well North Functional Medicine is her Denver-based functional medicine practice, serving patients all throughout Colorado and Utah. Welcome, Alison.
Hi, Brandy. Thanks so much for having me today. I'm excited to chat.
So to start off, I would love to hear more about your story, how you were in academic medicine and then decided, hey, I think we need to look at this a little bit differently and explored more of that functional route.
Yeah, so I started my career as a nurse. We lived in Washington, D.C., and I worked in the neuro ICU at Georgetown Hospital. And after a few years there, working like days and nights and swing shift, I kind of had an epiphany that I wanted to be more on the kind of preventive side of healthcare. So that's when I started looking into going back for my nurse practitioner degree. And my kind of focus at that time was I really wanted to do traditional primary care. And I think that was kind of where the thought was, like, I can really make a difference, like help get these patients healthy so that they don't end up in the neuro ICU and in the hospital. And I loved my training in family practice, seeing kind of all of the different specialties, but kind of came to a quick realization that that wasn't really what I thought of in my mind as true preventive medicine. As most of the listeners, and you know, Brandy, the visits are really short and it's really kind of more problem focused. And there's not a lot of time to spend counseling on things like diet and lifestyle. And, you know, people would leave and, you know, maybe they would feel better or their labs would look a little bit better, but it wasn't really truly getting to that like root cause. And I wanted more. I kind of paired that, I guess, with the fact that when I moved to Denver after I finished my program in 2016, the job market in family practice, I mean, maybe a blessing in disguise, was not great. So I landed back in neurology working at the University of Colorado and interviewed in some different subspecialties and really found kind of my niche in headache medicine. So I worked in the headache and pain clinic for almost a decade and I loved it. The group that I worked with was really supportive of lifestyle practices. We did a lot of really great work, you know, had workshops on non-pharmacologic headache approaches to treatment, and really was able to kind of bring in some of my passion for lifestyle, because as we know, pain and especially migraine, there's so many lifestyle variables there, but it still kind of wasn't exactly what I was looking for. It was, you know, pretty quick visits, not a lot of time to spend investigating. I truthfully didn't know what functional medicine was until probably about 7 years ago, maybe, where I started seeing some patients who were seeing some providers and seeing some like really interesting results and tests and things. And it kind of piqued my curiosity. But it wasn't until actually I started struggling with some health stuff, and kind of how I got interested in more of the thyroid health is with my first pregnancy, I was diagnosed with Hashimoto's and didn't think much of it at the time, like got put on Thyroid, was well managed. There was, you know, seemingly at the time, no complications from it. But postpartum, it kind of rocked my world. And I also had this kind of just wildly fluctuating TSH that we were kind of constantly chasing with different doses of levothyroxine and still not feeling great. And it wasn't until we were going to get pregnant for the second time and I had some trouble. So we were trying for a few months and, you know, really weren't having any success. So I started thinking like, maybe it's my thyroid, or looking to see like what else could be going on. And my TSH kind of always bounced around between 2 and 4 and 5. And at that time it was in the upper end of normal. So I think it was like 4 point something. And I, reached out to my primary care and was like, hey, we're trying to get pregnant and my TSH is a little bit high. Do you think maybe that could be a cause? And she was like, no, if you get pregnant, they'll adjust your medication at that time. And I was kind of like, well, that's the problem. Like, we're not getting pregnant. And I think this might be part of it. So I kind of started seeking out more of my own kind of integrative practitioner. And thankfully at the time, my OB was a friend of mine who I did my training with. And she was like, oh yeah, we definitely need your TSH to be like below 2.5, which is the, normal kind of standard guide for pregnancy and fertility. So really, literally within like weeks after my TSH was back down to like 1.7, we got pregnant and like never really looked back. During that pregnancy, I really changed a lot of like my lifestyle habits, my family's lifestyle habits, how we were eating, the products we were using, and started diving more into functional medicine and kind of never looked back. I really, I wanted to help patients more kind of understand this. And from my perspective, I was, I always thought like, gosh, I'm a provider and I had such a hard time navigating the medical system and kind of advocating for myself, even that there just has to be so many other women out there who are in the same boat where they're getting told like everything is normal and, maybe it is normal, but it's not optimal and they don't feel optimal and they have these symptoms that need and should be addressed. So my husband at his urging was like, you should start your own thing. So I, took that leap of faith. I did stay on part-time as faculty at the university for a few years as kind of things were up and coming and building, but I have since exited there and totally doing my own practice here, Well North Functional Medicine, as Brandy mentioned, kind of seeing women throughout the spectrum. But I do a lot of thyroid management because it's such a need and it's such a missed thing in conventional medicine, as we'll get into, where, things might look normal, but patients still can have a lot of symptoms.
Yes. Oh my gosh. I love that journey that you had and like how you had to advocate for yourself. You really had to be like, hi, I think this is a problem here and I want somebody to address this. Can we please work on this? And you had to raise your hand a few times to get the attention you needed. I hope every woman that listens to this podcast takes away, like that is one of the main foundational things about Healthy Buzz podcast is like giving women the tools to help advocate for themselves, finding those practitioners that will actually listen to your needs because you know your body better than anybody else. And when something's off, you definitely need to, unfortunately, have to kind of fight tooth and nail to get the attention that you deserve.
Yeah, absolutely. And it is something I'm sure you hear all the time, Brandy, of like, well, I've been told everything's normal. And sometimes I feel like patients come to me and they expect like the same thing. Like, I don't know if you're going to actually find anything or you're going to be able to tell me anything. Or their labs will come back and they'll be like, I like kind of anxious to meet, thinking everything's normal or everything looks okay. I'm so worried. Like, what else could it be now? So I think I also like strongly just advocate for patients. Like, if you don't feel good and when something is up and something is wrong in your body, you just really have to keep advocating. And sometimes it is going through a handful of providers to find the one that fits. But yeah, just a huge advocate, having experienced this myself and seen it so many times with patients, that sometimes you have to be the squeaky wheel, and that's okay to figure out what's going on.
Yeah, absolutely. So I do want to touch on that normal versus optimal. But before we talk about that, can we talk a little bit about the thyroid and what are the essential roles when it comes to the thyroid, in particular to like everything from energy to mood, metabolism, and even the pregnancy, the fertility journey?
Yeah, absolutely. So the thyroid is a gland. It's a butterfly-shaped gland that sits here at the front of our neck. It's basically one of our master hormones. So it's involved in nearly every body system in our bodies, everything from metabolism to digestion to mood to fertility and menstrual cycles, all the way to our skin and hair health. So it really touches every single system. I think a lot of people are kind of familiar with some of the hypothyroid symptoms, but the most common ones that we see are fatigue, exercise intolerance, intolerance, difficulty losing weight, feeling cold all the time, heavy, painful periods, sometimes absent periods. Infertilities is one that I see pretty commonly when we're looking at that side of things. Other stuff too, dry skin and acne, hair loss or hair thinning, constipation is a big one. Again, that's kind of where, like, just this week, 2 patients, normal thyroid labs, we've worked to optimize them, and they're like, my bloating is gone. I am having daily bowel movements, and that's the missing piece. So really touches every system. And that is by far the most common thing that we see in terms of thyroid. I always say it's kind of like the same coin, different side. Hyperthyroidism is the opposite of all that. So, difficulty maintaining weight, feeling hot and sweaty all the time, feeling more anxious, diarrhea instead of constipation, and just that really high metabolism, like can't get enough food, can't sleep, just really restless, kind of more of those symptoms. And, we see that again less, but we can see that, and especially in different phases of life. That's something that we'll tune in for.
I would say too, and we'll touch on like different medications, but sometimes if somebody's over medicated with their thyroid medication, they'll have those hyperthyroid symptoms.
Yes. Yeah, absolutely. And that's something I always, have patients look out for. Like if we're adjusting your dose, because sometimes it's a small adjustment and everyone's different in how they respond to these medications. I'll say, like, you've got to look out for these things. Let me know right away. That might mean that we're overshooting and we might need to back down. So yeah, that is actually a really common scenario where we see more hyper symptoms, but just hopefully transiently.
Hey, Healthy Buzz listeners. Are you feeling like you're constantly struggling to hit your protein goals? Like, you should be getting more protein for energy, muscle support, and overall well-being, but you're not quite for sure how to make that happen without sacrificing flavor or other important nutrients. I get it. That's why I created the High Protein Power Plan, a delicious and easy to follow 7-day meal plan designed specifically for women who want to effortlessly reach 130 grams of protein or more every single day. Head on over to bcw.becollectivewellness.com/high protein recipes to download your High Protein Power Plan today. So let's talk a little bit about the lab work and normal versus optimal. So you mentioned that your TSH was in the quote unquote normal range of under 5. It was 4 point something when you were trying to get pregnant the second time. But then when you got your thyroid, your TSH down to under 2, you were able to conceive pretty quickly after that. So can we talk a little bit more about that optimal versus normal range?
Yeah, I think the thyroid is kind of one of those like functional medicine principles that just shines. Like it makes so much sense when you like kind of step back and think about it. And when we do get it dialed in, it's like, oh yeah, that totally makes sense that why I wasn't feeling good. But yeah, I think that normal and optimal also similar. When you go to conventional medicine, they often are only running a TSH, which is thyroid stimulating hormone. This is a hormone that's not even technically a thyroid hormone. It comes from the pituitary gland in the brain and talks to the thyroid. TSH is more of a screening tool that they'll use in conventional medicine. That's all they will often run. And the normal range on like our standard labs like LabCorp, it's 0.5 to 4.5. If you don't fall outside of that range, usually there's no additional testing that's done. And that's really kind of unfortunate because that is really just one piece of the puzzle. And it doesn't tell us actually all that much what your thyroid's doing and how you're able to utilize these thyroid hormones. So even within that range, we kind of think of where is more optimal. I always tell patients the closer to 1, the better, but we're always aiming for less than 2.5. And that is, falls in line with the American College of Obstetrics and Gynecology for fertility. We want that to be below 2.5 because we know that helps increase like odds of healthy live birth, reduces the risk of miscarriage, all those things in terms of fertility. So I'm always shooting for those more optimal ranges. But beyond a TSH, the things that are more important are things like free T4, free T3, thyroid antibodies, sometimes a reverse T3. And these are all more specific thyroid markers that kind of tell us a lot more about the picture of your thyroid health and how you're able to utilize the hormones than just a TSH. So when we kind of go back, again, TSH talks to our thyroid releases T4. T4 then has to be converted to T3, kind of peripherally through the body at a tissue and cellular level. So free T3, in my opinion, is like the most pivotal lab marker. So if we can get that to more optimal ranges, that's where we often will see symptom resolution. So I always tell patients, if you've had a normal TSH and sometimes even a normal free T4, if you're not converting that, which we could go into like all the reasons behind that, we will still see symptoms persist. And I think this is where a lot of patients get lost with endocrinologists and PCPs because they kind of really focus on this TSH and free T4 and their levothyroxine dose. And they're like, you're good. I don't know what else to tell you. I think, you might need to go see a therapist if your mood is not great, or GI if your constipation's still there. And they just kind of get tossed around. So that's where that free T3 really comes into play, because it is our active usable thyroid hormone.
Okay, so I would love to hear more about that conversion issue. So it is a very complex thing. And when we're looking at the thyroid, like Alison said, the TSH is only going to be how the pituitary gland is communicating with your thyroid gland. It doesn't actually give you a representation of like how much thyroid hormone is being produced. But then we have that T4 that is mainly produced that needs to be converted to T3. Before we talk about why there could be conversion issues, let's talk about like why are conventionally trained practitioners only, maybe if we're lucky, they look at a free T4, but they're not looking at that T3. Why do you think that is?
My only guess, honestly, because I feel like, especially in endocrinology, like there really should not be an excuse for it at this point. But I think the reason they look a lot at T4 is because that's what they treat with. So when we think about standard treatment of the thyroid, they're using levothyroxine or brand name Synthroid, which is synthetic T4. So to them, it's like, we're giving you this T4, we should monitor that, and we'll see what happens with your T4 and your TSH. But they don't often go beyond that unless you ask for it. And then sometimes they will. If you've got a great endocrinologist, they'll look at T3. They might actually give you some T3, and they might be open to different formulations. But that's my really only suspicion. Now, I don't know. It's, medicine takes so long to change, and hopefully we'll see this. But that's my thought, is just like, that's what they're treating with. That's what they're going to look at, and they're not going to really go beyond that. Do you have any other like insider suspicion of why that is the case?
Yeah, I think it's that, but then also I wonder if there's a little bit of maybe undereducation and not really sure what to look for with the T3. And then they feel like, well, if their T3 is low, and since they're not using maybe the other types of medication, which we'll talk about medications coming up here in a little bit, but like maybe they don't quite understand how to manage the care when the T3 is low.
Yeah, I think totally. I mean, and that could be the case for primary care, right? I always say like primary cares, they have a lot that's going on in their clinics every day. They're seeing so many patients, and it just might not be in their wheelhouse. And that is the case in conventional medicine. I mean, having been in that system for 15 years, a lot of times providers would literally just say like, I am not going to check this because I don't know what I would do with it. Right? Like we would hear that all the time with like a fasting insulin or, different nutrient levels. It was like, I'm not going to, do anything with it. So why would I check it? So that might be part of it. And, maybe some fault of theirs, maybe the system that they just don't have a lot of time to, educate themselves and kind of dial in this practice. But yeah, I think that might be the case for primary care, but endocrinology really like they should know, right? How the thyroid functions and the importance of the T3. And there are some good ones out there. We've got some great ones here in Denver, but by and large, it is still just that TSH and T4.
Yep. So you mentioned about the conversion issues, because since the body does need to convert that T4 to the usable form of T3, where we're going to see the biggest impact on all of these symptoms, because a lot of the symptoms that Alison was describing were like the low thyroid symptoms, right? The weight gain, the issues maybe with constipation. I mean, you can even on labs see cholesterol levels be elevated when the thyroid's not working optimally. So when we think about like all of those symptoms, what are the reasons why maybe the body is not converting that T4 to the usable form of T3?
Yeah, I mean, as most things in functional medicine, it is multifactorial. So we often will see nutrient deficiencies or insufficiencies play a big role here. So things like zinc, selenium, iodine, B vitamins, magnesium, vitamin D. If we have any deficiencies or even like insufficiencies, or maybe we're on the low end of the lab range for those, we will often see suboptimal conversion. Other things, so lack of sleep, lots of stress, chronic viral illnesses or gut dysfunction, things like SIBO or dysbiosis, toxin exposures, even things like fluoride, it competes with iodine. So we'll see poorer conversion of T4 to T3. And then honestly, like having done this now for a while, there are just some people who, despite having all of these things dialed in, just really poorly convert. Like we have everything on point, like their gut is functioning, their nutrients all look great, they've swapped all their toxins and products and doing all the right things that we say, and they still really just are poor converters. And that is something that, maybe there's some genetic susceptibility perhaps. They really, deserve to then have the right medication if they are not going to convert their T4 the correct way.
Yeah, absolutely. I myself have been a hypothyroid person for quite a while and have been using thyroid medications with my practitioner for a while. And I think part of mine was I was an interventional radiology tech for over a
Oh,
decade.
sure. Yep.
And for those first 6 years, I did not wear a thyroid shield.
Yep.
I probably damaged my thyroid.
Totally. Yeah, absolutely. When you're doing that day in and day out, for sure.
Yep. And then, thinking about the stress picture too, like I was a long distance runner. I did multiple half marathons. I did a marathon, definitely was overtraining, underfueling
Yep.
my body, not prioritizing sleep, all of these things. Your thyroid can take a hit with it. I do want to talk about like the nutritional deficiencies and like under eating, or maybe
Yes.
like the
Yep.
influence that diet culture is having there, some of these trending different
Yep.
diets too, like keto and carnivore. How are they impacting our thyroid?
Yeah, that's a great point. And you mentioned like being a distance runner. And, here in Colorado, we have a lot of those folks. And I see a lot of athletes in my practice. And just in women in general, I feel like there's so much underfueling, whether it's for endurance activities or just daily life. And that's one of the biggest things I talk about with patients is like, we need to nourish our bodies. If we don't, they perceive that as stress, right? It's like, it is a form of stress if we're undernourished, especially if it's like chronic undernourishment. And our thyroid is the first thing to take a hit. And then we see the dominoes fall. If the thyroid is suboptimized, that's when we start to see the sex hormones will be a little bit lower. So progesterone, testosterone, estrogen, get wonky periods or irregular cycles, absent cycles, all those things that kind of fall downstream for a lot of women. But yeah, I think it's a huge problem, right? I think there, has always been this kind of diet culture where we're restricting something, whether it's carbs or fat or what have you, the time we're eating. Like, I think that's been a recent one that I find really impacts women is they think the, intermittent fasting or time restricted eating is they're doing themselves a favor. Maybe they think they're going to lose weight, or they just say, I feel good doing this, or I'm not hungry when I wake up. I'm always like, that's not a good sign. That's a good sign that our metabolism is shot and your thyroid is probably also taken a hit because of that. I always just say like, it's really hard if you're trying to get all your calories and nutrient needs into 2 meals. Like it's impossible for most people, I would say, especially women. I think, we need to focus more on nourishment and bringing in what our bodies need. So lots of fiber and phytonutrients and protein and fat. And the thyroid does need carbohydrates. So that is one area where if I see women come in and they're low carb or keto, I'm like, we got to get some carbs in because that is going to help fuel your thyroid and your hormones just generally. So I do think diet culture plays a big role. And sometimes it's a hard thing to tease through, but I always, kind of just bring it back to patients. Like we have to nourish our bodies to feel optimal and function optimally.
Yes, absolutely. I also talk about like with that intermittent fasting, not only is there the nutritional deficiencies that can happen because you're underfueling, whether intentional or unintentional, right? Because I think that sometimes too, people are unintentionally underfueling. They don't quite understand the needs that their body has. They've been a little disconnected. But then also like the digestive stress that you put on your system, like you're cramming
Yeah.
all your meals into this little 8-hour window and you're like, okay, body, digest all of
All
these
of
nutrients,
this.
all of this protein and use it. And your
Yep.
body's like, whew, we cannot do that all in 8 hours. Please give me more
Totally.
time.
Yeah, absolutely. And then we see stuff like SIBO pop up, and then nutrient deficiencies are even worse. And we can't absorb the nutrients if there's infections and things going on. So I totally agree with that. It's kind of that domino effect. And sometimes it's totally unintentional, right? Women are busy, they get up, they have their coffee, then they're off to work or getting kids to school. And, the next thing they know, they've dove into their email or their in basket, and it's, 11 or 12 o'clock. And I do hear from a lot of patients that they kind of do this for so long long that they don't actually feel hungry in the morning. And if they do eat, they actually feel kind of nauseous or almost like it doesn't fit right. It really is a sign. Like maybe you just ease into it. So I always say, like, we'll start with something small, but in a month or two, you will wake up feeling hungry within the first couple of hours. And that's how it should be. We need those hunger signals to kind of like make their way back to us.
Yeah. And I do see what happens sometimes too is like with those GI symptoms that people they like avoid eating because when they eat, they're bloated, they have acid reflux. We need to address what's going on in your GI system because that's not normal. You shouldn't feel bloated after every meal or nauseous and things like that.
Yeah, absolutely. And then it's again more of that underfueling unintentionally where they're just like, I'm miserable. So I'm going to eat as little as I need to and will feel good afterwards. Or they're restricting whole food groups and categories. And then that's when we see those nutritional deficiencies kind of compound when we're just skipping over all of these great foods.
Yeah. So you mentioned earlier about some different medications when it comes to thyroid health. Can we talk about those? Because there's some that you mentioned are supporting T4, but in what ways is that beneficial? What ways is that maybe missing a big picture? And how can we differentiate between like what is the right option for a woman?
Yeah, absolutely. So there's, I would say, kind of broadly two categories of medications. There's the synthetic, kind of classic pharmacologic ones that are levothyroxine and Synthroid, which is synthetic T4. And then there's synthetic T3, which is also known as levothyronine or Cytomel. And those are kind of the standard ones that you'll get in conventional care. They still work really well for some people. And then there's a whole nother class, which we call the natural desiccated thyroid extracts, which have been around for a very long time, longer than the synthetic versions. And these are things like NP thyroid or Armour thyroid. And I think the benefits to these natural desiccated compounds is they have a combination of thyroid hormones. So they're porcine derived thyroid glands. And so we're getting T4, T3, and then a little bit of T1 and T2. Those tend to be my favorites for patients. I do still prescribe regular ones as well. And there are some patients who respond to, just regular levothyroxine, and that's great. If they're able to convert that T4 to T3, wonderful. It's cheap, it's covered by insurance, it's easy. We do run into some issues where, some of the generic formulations have binders in them and some of them have gluten. So I've had some patients who have celiac disease and they have no idea that that could be the case, in which case they have got a lot of symptoms still, they don't feel great. We'll switch them over to something even like Tirosint, which is it's a very pure formulation. It comes just as a liquid or a really great gel capsule that's very easily absorbed. And that is my preferred form of T4 if we are going to use one, if we have to. But again, there are some patients who do totally just fine on levothyroxine, and that is great for them. Yeah, I will say it's more of the exception than the rule. A lot of times we're adding some T3, switching to NP thyroid or Armour thyroid. But there is a case, and I do often start at a T4 and just like, let's see what happens. Like, are you going to convert it? I also, I hesitate for some women if they're really iron deficient, adding in a lot of T3, because we'll see a lot of those cardiac kind of symptoms with if you're iron deficient and then we pour a bunch of T3 on because it is quite short acting. So we'll see more palpitations or tachycardia. So there is a case where sometimes we got to work on iron repletion first, and then maybe we'll add in some T3. But I would say in my practice, it's probably like a third of patients are just on T4, a third are on combination T4 plus T3 synthetic, and then there are some, maybe a third on NP thyroid. So maybe leaning a little bit closer to the NP thyroid being more dominant, but it truly should be personalized. Not every patient should be on the same dosing regimen, even titrating. I have the patients who are really sensitive to medications and we're just going to go a lot slower, even doing like really baby doses until we kind of dial in and get the right dose. But it is really, it's kind of an art. It really isn't like, you follow an algorithm and that's what it is. But we do see, when we're diligent about kind of rechecking in on labs and then also symptoms, like that's the biggest thing is, your labs could look pretty good, but if you're still having a lot of symptoms, maybe we do need to push you a bit more to that optimal end of the range.
Yes, I love that. So it's not always just chasing a number, but rather seeing how the client or patient feels with their different
Yeah.
dosing. So when we're thinking about thyroid and somebody starting on a thyroid medication, I find that often they're just like given this medication and then maybe go back in a year, maybe get their thyroid recheck. What does rechecking look like? Because it sounds like that's something you do.
Yeah, so I always like to check like a full thyroid panel again in 4 to 6 weeks. So, that's around the time that we should start to see things move. We might closer to that 6 weeks start to see some symptoms improving as well. But I like to check in because I also don't want patients to wait and feel miserable. We might even adjust medications within that 4 to 6 weeks. So I often will reach out in a couple of weeks to patients and say, "Hey, how are you feeling?" If they're feeling good and fine, we might bump it up a little bit and then, say, okay, 4 weeks, let's check in and see how things are going, and then let me know if you feel any, hyperthyroid symptoms in the meantime. Otherwise, we'll check it. But I am, a fan of looking at numbers to make sure that we're not overshooting it. But also, let's not wait 3 or 6 months. If you're not feeling good, let's figure out what the right combination is for you, the right dose, and make adjustments sooner rather than later.
Yeah, I love that. You're giving like this personalized care and like actually making sure that the things that you're recommending for your clients are actually working for them, which is so
Yes.
important.
Yeah.
Let's talk a little bit about why women seem to be more affected when it comes to their thyroid health, but then also the impact that perimenopause and menopause play on the thyroid health.
Yeah, absolutely. You hit the nail on the head, Brandy. We see women, predominantly have more thyroid disease. And I always say it kind of pops up in the 3 Ps. So, pregnancy, postpartum, or perimenopause are some of the most dominating times where we'll see a hypothyroidism or autoimmune thyroid disease pop up for women. I don't know that we know specifically, but the speculation is that it has to do with hormones and the change of hormones during those times. So during pregnancy, we get the drastic surge of hormones. Postpartum, it's that drastic crashing down. And then perimenopause, it's the roller coaster followed by the disappearance of our hormones essentially. And with that we will see that pop up for women. Thankfully in pregnancy it is pretty standard that they check that with your first set of labs, because in pregnancy baby relies on your thyroid for the first trimester. So it's really important that that is dialed in, and if you need replacement that it's given, so it reduces the risk of low birth weight or preterm birth, gestational diabetes, things like that. But in perimenopause a lot of times these symptoms that we talked about mimic the symptoms of estrogen and progesterone and testosterone declining. So there are a lot of patients who I see that gets kind of swept, they don't really check that, or they're just told like, well, you're in perimenopause or you're postmenopausal and this is just kind of the way it is. And thankfully we're seeing more in the realm of, advocating for women's health kind of across the board, and especially in perimenopause and menopause. But I do always, because I do, perimenopause and menopause HRT as well. And what I think, from a functional medicine perspective is we got to make sure like nothing else is going on first. So if we're not checking your thyroid in perimenopause, how do we know it's your hormones and it's not your thyroid? So, I think really doing our due diligence and, doing that good functional medicine approach and making sure those foundations are met in perimenopause and that your thyroid is optimized is, for one, just you're going to feel better. But also, if and when we do need to start you on hormones, we're going to dial them in so much quicker. And I find that kind of time and time again, that when we take that foundational approach where we're looking at your gut health and toxin exposure and stress and sleep and all of these different functional medicine pieces, the thyroid included, I always say hormones are kind of like the cherry on top. So once we have all those foundations in place, then we see that hormones, we can dial in the doses much quicker. People feel better. There's less side effects just because we've set people up for success. But yeah, we definitely see, like back to your original question, lots of that in perimenopause. And part of that too is, when we lose estrogen, we have this immune system shift that happens, which is where the autoimmune thyroid piece kicks in a lot. And I mean, during all of these time periods, whether it's pregnancy, postpartum, or perimenopause. So we'll often see those thyroid antibodies will be elevated and the TSH will start to climb.
Yes. Well, that leads into the next thing I was going to ask you about is the autoimmune issues with the thyroid. So those are typically Hashimoto's, correct me if I'm wrong, Hashimoto's thyroiditis and Graves' disease. Could you speak a little bit about each of those different autoimmune issues that affect the thyroid?
Yeah, so they're the most common reason we have like a hypo or hyperthyroidism. There are some genetic cases where it's more of like a primary hypothyroidism, but for the vast majority of patients, they will have positive thyroid antibodies, which constitutes the autoimmune property of either Hashimoto's or Graves' disease. So Hashimoto's is it's the autoimmune process where we see the hypothyroidism. So again, those low thyroid symptoms. This again is the most common. Graves is much less common, but still we see that. And I do treat patients for that as well. Again, it's kind of the same coin, two different sides where, we have this autoimmune process that might be popping up because your estrogen is declining. You've had, a big infection, big stressor, increased intestinal permeability or a gut infection that kind of triggers this autoimmune response. And it's often one of the first autoimmune diseases that we will see in a patient. So the thyroid tends to kind of be this like sentinel gland where it's, sort of the canary in the coal mine in that that's the first kind of domino to fall. We can check for these by looking at different thyroid antibodies. So the two most common that we look for Hashimoto's are thyroglobulin and thyroid peroxidase antibodies. For Graves, there's another one that's a little bit less known, but it's a thyrotropin receptor antibody. But it basically, when those are elevated, means that your thyroid is under attack. It's very inflamed. We can actually see that on ultrasound. When we do an ultrasound of the thyroid gland, it'll show inflammation kind of. Most of the time it's just diffuse. Sometimes it will be some kind of like nodular inflammation, but that means that there is an autoimmune process and your body is attacking the thyroid. And this, I always kind of explain to patients, I always check for them all the time anyways, because sometimes we'll see antibodies elevated, but totally normal and even optimal thyroid levels. And I explain it to patients that in conventional medicine, they may or may not check them. Oftentimes they don't. If they do, it's kind of like we check them once and then we say like, yes, you have Hashimoto's and like, we'll, come back when your TSH is high and then we'll put you on medication. But from a functional medicine perspective, we want to figure out like, why are you having this autoimmune attack? Why are you inflamed? And what can we do about it? Because we do see, and this is really especially seen in women, that we will collect autoimmune diseases. And that's not a good thing to collect. And I have several patients in my practice where the first, diagnosis was either Graves or Hashimoto's, and then it's celiac, and then it's Crohn's or ulcerative colitis, and then it's rheumatoid arthritis or an ankylosing spondylitis, and some of those more severe autoimmune diseases that are really life-altering. So if we can identify that your immune system is telling you something is off and you've got this inflammation, we can reverse it despite, again, what conventional medicine may say. We can stop this process so that you don't end up getting these other autoimmune diseases. Because if, we just let this train of inflammation run away, we will see these pop up. And it happens, more often than I would like to see. And the longer it goes on, the harder it is to kind of like pull back from.
Yeah. So with that, like what are the things that you're looking at to help with reversing the autoimmunity with the thyroid?
Yeah. Again, it's kind of all of those functional medicine principles. So we're always looking at the gut. Are there infections? Is there SIBO? Is there increased intestinal permeability? Almost always there's something there. We're looking at those nutrients. We're looking at stress. We're looking at toxin exposures. There are some medications and supplements that can be really helpful. So selenium is a great one. It's often, we can see antibodies go down even just with that addition. Things like myo-inositol and dechyro-inositol. And then I prescribe a lot of low-dose naltrexone, especially if we're looking at really high antibody levels, whether they're TPO or thyroglobulin, and it works really brilliantly. And I'm not sure if you've had anyone on that's talked about low-dose naltrexone, but I'm happy to if not.
Yeah, let's talk about it.
Okay, so low-dose naltrexone is kind of this really interesting compound. And we use it in conventional medicine for a long time for patients who have chronic inflammatory pain conditions. So things like fibromyalgia, migraine, those really more inflammatory-driven pain conditions. And naltrexone at high doses is used for alcohol use disorder and opioid withdrawal. And these are, much higher doses than we're talking about. So 50 milligrams for those conditions. For autoimmune diseases of many kind, but especially thyroid disease, I use it a lot. We're looking at anywhere from like 0.5 milligrams up to 4.5 milligrams. And at these low doses, it has a really interesting mechanism in that it helps reduce inflammation and improves immune system function. And we also see pain relief. So it temporarily blocks our opioid pain receptors. So we get this surge of endogenous or our internal, like, feel good chemicals, opioids. So we see that it works brilliantly for pain. And again, I used it in my conventional medicine setting for a long time with that. But we also see really great improvement in autoimmune diseases of many kinds. But thyroid antibodies seem to respond particularly well to it. It is kind of a more of a longer game therapy, but it's cheap, it's effective, it's pretty well tolerated. And we'll see antibodies drop, in 6 months by 50%. And then at a year, we might see them go down even more. But I've had patients, many reverse their antibodies with low dose naltrexone and all the other lifestyle pieces as well. But yeah, lots of other conditions. Rheumatoid arthritis. I have one patient we were able to get off for biologics. She has zero symptoms, zero signs of disease, and inflammatory markers are totally negative. And pain is well controlled on just this like kind of novel molecule it's not FDA approved. It is a compounded medication, but it can work really great for a lot. Endometriosis is another one that I see really good results with.
Wow, that's awesome. Like thinking about the way that, yes, conventional medicine still plays a role. If we think about even just thyroid health in general, like the different medications that we're using, but then also this low dose naltrexone can be really beneficial for somebody who has the autoimmune thyroid issues going on. Now, with thyroid issues, often people can hear about removing gluten from their diet. Can we talk a little bit more about that? Because I have this conversation with a lot of my clients, and I think there's a little bit of misunderstanding sometimes because they think about a gluten sensitivity related to their gut versus why we're removing gluten in an autoimmune issue.
Yeah, and this is kind of one of those that I also recommend it, at least as a starting place. But I find that not everybody needs to remove it forever 100%. But when we think about gluten, for a lot of patients, it is that kind of autoimmune reactivity. It can degrade the lining of the gut, which then we get the leaky gut or increased intestinal permeability and subsequent autoimmune disease. So especially, the gluten here in the US, which I'm sure you hear from patients all the time, it's very hybridized, lots of chemicals on it. And that's where we see it like be the most detrimental. But we also have this kind of idea of it's called molecular mimicry with gluten, where it kind of mimics our thyroid gland or the cells of our thyroid gland. So if we have this autoimmune propensity and we are eating gluten all the time and having a lot of gluten, our body then is on high alert and it's kind of like, oh, we've got a lot of this. And then they see the thyroid and they're like, this looks similar. So we're going to attack that too. So there is kind of this component of molecular mimicry. So I do always recommend, especially if thyroid antibodies are really high, like let's give gluten-free a trial. Like if you can give me 3 to 6 months, like full gluten-free, we can really see antibodies decline. Once we get antibodies to go negative, which we can do, and this was part of mine, I went gluten-free for an entire year. My antibodies have since been negative. Lots of other things in the works there too, in terms of like gut healing and low-dose naltrexone, but it's been something that I can now, like I eat not every single day, but I can have it and my antibodies have stayed negative. So it is kind of one of those things that I'm like, it might not be forever, but it's pretty amazing. People generally feel good when they eliminate it. And we'll see, their constipation resolves almost immediately, like within the first couple months. Then it's kind of like the proof is in the pudding and they're like, okay, I'm on board. We'll give it a try and we'll keep looking at these antibodies.
Yeah. I find too, sometimes like I recently had a client who we discovered antibodies on her thyroid labs. And so I referred her back to her doctor to walk through the process of like, what do we do next? And they kind of threw at her like, I need you to do the AIP diet. And I was like, too much, too fast.
That's a lot. Yeah.
The AIP diet, explain a little bit more about what that diet is to our listeners and why that can be beneficial, but then also why it could be challenging.
Yeah. So, and you may know it better than me because I honestly very rarely recommend it, but it's like this autoimmune protocol diet that removes like any possible inflammatory trigger. So we're talking gluten, dairy, sugar, grains, generally speaking. I think the biggest thing is it's very restrictive. And for one, it's not sustainable. It's not enjoyable. It does bring on a lot of stress. I find when people do try, especially if they're trying to adhere to these more strict elimination elimination diets for a long time, the stress that it creates is honestly just not worth it. But it also, we're missing then these whole food groups where then they might be dealing with more of these nutrient deficiencies or under fueling, like we talked about. Is that kind of similar to your experience with patients who have been on this, Brandy?
Yeah, exactly. It's just so restrictive that I'm always like, let's start with gluten-free. Let's start there. Something that feels more achievable, that is sustainable. And after a few months, let's bring it back. Let's, of course, keep tabs of how you're feeling, because this is a big player in this. Yes, you can remove all the foods in the world, but if you feel like shit, regardless of the foods that you're removing, like, why are you removing all of them? Same with the AIP diet. It can cause so much stress to be like, no, I can't eat that. I can't eat that. I can't eat that. I can't eat that. And it limits this palate, because I think you also have to remove legumes. Like, it's very restrictive. Like, you're stuck with like fruits, vegetables, and proteins, animal proteins.
Yep.
Pretty much. And so it can be really hard to get all those nutrients, which we need the nutrients to then make the thyroid hormones, but then also your body in general, all of its hormones. So yeah, I find it to be extremely restrictive. And there was only one client that I did AIP with, and it was from her doctor's recommendation. And she was a functional doctor, and we had done many months of other things to reduce all the inflammation in her body. And it was like, let's try 1 month of AIP and see how you do. And that was where then I was giving, here are some recipes and meal plans of foods you can eat. So she didn't have to think about like, these are the foods I can't eat. We had to switch that to be more abundant of, these are foods that you can eat.
Yeah, absolutely. Because I think it can also get then patients, and I see a lot of patients coming to my practice where they're, scared to eat things, or they've been on these elimination diets for such a long time and they're worried about reintroducing. And it just kind of gets into this tricky pattern. Truthfully, I mean, I'm not a nutritionist or a dietitian. So if I have patients on, a more strict elimination diet, that's where I will refer them, because they need someone who can help them with, meal plans and even just ideas for snacks and kind of walk them through it a little bit more. So I will recommend kind of basic stuff, like maybe let's try eliminating gluten or dairy, or maybe both of them if we suspect it might be for a short time. But beyond that, I will refer usually to a nutritionist just to have that extra layer of support, because it can be really challenging, especially if you're already not feeling good, to then have this whole mind-boggling task of like figuring out what you can actually eat and make sure that you're doing it properly.
Yeah, exactly. So one thing that I do want to touch on, so with the autoimmune stuff, is we talked about how low dose naltrexone can reduce the antibodies. Will clients have the same effect from a thyroid medication like Synthroid and P-thyroid? Does that reduce the antibodies?
Sometimes, but not typically enough. I mean, we might see that maybe it reduces the stress on the thyroid a little bit and they might tick down a little bit. But honestly, no. Like, to get the thyroid antibodies to go really, or like totally negative or really reduce, it is such a multimodal approach. And it is, it's nutrition, it's gut health, it's sleep, stress management, it's, trying some of these other, potentially nutraceuticals or medications. It's not something I see medication resolve. I don't think I've ever seen it fully resolve with just like replacing the thyroid medication.
Yeah, it's going to be kind of that whole dietary and lifestyle approach to reducing the overall inflammation going on in the body, finding out what's happening in the gut. I'm always like, what's happening in your gut when somebody has autoimmune issues? I'm like, we need to see what's happening in your gut, because that's foundational for your overall health.
Absolutely. And I mean, you'd be hard pressed to find a thyroid patient who does not have symptoms in the gut, whether it's bloating or constipation or nausea. So it is usually one of those things we're already thinking about. But once we see the antibodies, it's like, okay, we got to definitely zoom in there a little bit more and work on like a gut protocol. That definitely happens anytime I see those antibodies be positive.
Yeah, absolutely. Or are there any final things that you want the listener to know when it comes to thyroid health and how to support their body? Or even like when they're working with a practitioner, what should they be inquiring about?
Yeah, I mean, I think, again, kind of like we mentioned at the outset, it really is that advocacy piece and not taking like you're fine for an answer or things are normal, but you can seek out. I mean, I have many blogs on my website where I kind of talk through a lot of this stuff. I've got the lab ranges that you should look for. There's a lot of resources for those. The Institute for Functional Medicine, Rupa Health, they've all got some great blogs that kind of walk patients through this. So if you're looking for those resources, definitely, it's always good to have in mind mind, like, where should things be? Because I think that's helpful for patients to, the lab ranges are just so wide. And then if they fall within that, they usually are like, okay, well, I'm good to go. So I think kind of, knowing where things maybe are more optimal and then seeing how that aligns with your symptoms and then advocating. And if your provider that you're working with is not open to different medications or doing a full thyroid panel, or they don't know what to do with your thyroid antibodies, it's a good sign that maybe you should look for someone else. And there are primary cares out there who are more integrative. Functional medicine really, though, is that whole approach where you're not just going to get a medication, you're going to get more education on your thyroid and why it's important and how can we really optimize it.
Yeah, absolutely. Sometimes, unfortunately, you do have to shop around, or we just made a one-stop shop for you. You talk to Alison, but locate her. She works with people in Colorado and Utah. You can connect with her. And I can also help you find practitioners as well to help connect you as well. Alison, where can people find you? How can they connect with you?
Yeah, so I am over mostly on Instagram at Wellnorth Functional Med is my Instagram handle. And then my website is similar. It's wellnorthfunctionalmedicine.com. Over there, I've got, a booking link. If anyone is in Colorado or Utah, I do offer a free discovery call. So always happy to kind of talk through symptoms and see if we'd be a good fit to work together. And then, like I said, I do a lot of blogs. That's kind of my main form. I enjoy writing and kind of educating. So if you hop over there, I've got probably dozens of thyroid blogs on different topics, whether it's fertility or pregnancy, Hashimoto's, and you can find a lot of good resources over there.
Amazing. All right, everybody go give Alison a follow and connect with her about all your thyroid and HRT. She does HRT too. So all of your questions that you may have regarding that. Thank you so much, Alison.
Thanks, Brandy, for having me. This was super fun.
Thanks for tuning in to another episode of Healthy Buzz. I hope this conversation has left you feeling seen, supported, and ready to take the next step in your health journey. Love what you heard? Make sure you subscribe to Healthy Buzz so you never miss an honest conversation. And if you found this valuable, please take a moment to leave a review. I truly appreciate it. For exclusive weekly tips and holistic strategies, be sure to subscribe to my weekly newsletter. The link is in the show notes. Remember, this isn't just nutrition, it's permission to trust your body. I'll catch you on the next episode of Healthy Buzz.